Hello, everybody. I believe we're live now. I'm Dr. Michael Verbora. I'm the medical director at Field Trip Health, and I want to thank everybody for joining us today. And with me as well is Dr. Joseph DeLeo, and I'll let him introduce himself.
Rehabilitation psychologist and the director of clinical therapy here at Field Trip Health, and I'd be happy to answer any questions about the therapy that we're working on.
So thank you, everybody, and I'm going to get started with our presentation for today, and both Joseph and myself will stay present for questions at the end of the presentation. There's also polls on the right side of your screen and areas where you can ask questions, so feel free to engage. We will do our best to respond. Okay, so I'm going to get started now, and today I'd like to talk about psychedelic-assisted psychotherapy. Before I get started, just a little bit about myself. I have a medical degree from Western and went on to complete my family medicine training at the University of Toronto. I am now the medical director at Field Trip Health, and I also am a faculty at McMaster University. I do some work with medical cannabis as well and have been doing so for a number of years. And I'm also a student health physician and professor at Seneca College. I don't know what percentage of people are aware of the paradigm shift that's taking place currently, but there really is a battle for how we're going to manage mental health moving forward. And it seems to be quite a split currently. In my conversations with colleagues, particularly psychiatrists who are graduating, they seem to be divided into two camps. One being the camp that thinks we should continue with the current approach, which is taking a pill every day, which is really causing emotional blunting. And so this is what we do daily now, is we give people antidepressants, and they do work better than placebo based on evidence. But one of the biggest caveats to them is that patients will come back and say, while they make me numb to the negative, they also make me numb to the positive. And so they feel flat. And I'm not necessarily sure that they're helping people achieve their best, live their best lives or achieve the best version of themselves. And then the other camp of individuals feel like there's a different approach, and that's really using more rapid acting antidepressant agents, which are typically psychedelics. And this approach is very radically different to antidepressants in that this is allowing for healing, and this is allowing for emotional breakthroughs and processing. And typically these experiences that these drugs create are extremely transformational or mystical, and they really lead to immense insight, which really helps remove the barriers that cause the anxiety or the depression or being able to move through traumas, which are the blockages of many people's mental health. So today we're going to talk a little bit about the history of psychedelics. We're going to go over some of the different drugs so that you're educated on them, review the risks and harms of them. We're going to talk about ketamine and specifically what IV versus drug-assisted therapy is. We're going to talk a little bit about the renaissance in the research that's taking place, what the future looks like. And then, of course, I'd like to share with you what Field Trip Health has to offer. So first of all, let's talk about psychedelics. So if you would have asked me maybe 5-10 years ago what I thought about psychedelics, this is probably the image I'd have in my mind. A hippie culture, mostly recreational, individuals looking for escapism. And that was the impression I had, but I was not very well educated, and there was definitely no education whatsoever in medical school on psychedelics, neither negative nor positive. But if you ask me today, based on my understanding, review of the literature, research, conversations with patients who've used this and therapists and other physicians, I have a very, very profound different impression today. And that is that they are really tools to help open our minds, to help us do our own work, to help us heal and move forward in life. And so I have this view now in my mind when I think of psychedelics. And I hope with more research and talks like this, you'll be able to have this opinion as well. What does the word psychedelic mean, or where does it come from? Well, it can be divided into two words, psyche and delune, which really means mind or soul manifesting or revealing. And really, psychedelic is a mental state that is characterized by a huge sense of intensified perception and sometimes distortion. And some people will call these hallucinations or visions. And usually they're accompanied by extreme euphoria. Now, not all psychedelics cause positive psychedelic trips. They can be very difficult trips, not necessarily negative, but sometimes you get what you need, not what you want, but they're supposed to be mind revealing and allow you to move forward. So let's talk a little bit about the history of psychedelics. I'm not going to spend too much time here because I could spend hours alone just talking about the history and the wide variety of different drugs. But I think it's important that you understand that there's quite a wide background of different psychedelic drugs. These drugs go back, into the early 1900s, into the 1800s, and even earlier. And there's a whole host of them all across the world. Some of these may ring a bell, like peyote or DMT or MDMA, LSD, psilocybin. So all of these drugs come from all different areas of the world. They have very complex histories. And we've actually done a lot of research with them many, many years ago. So there's actually over 1,000 scientific papers, believe it or not, in the 1950s and 60s, particularly on LSD. And thousands of patients have used this in a research study, and millions have used it outside of the research setting. And we've learned that some of these psychedelic drugs are actually quite safe. People do not die when they take these drugs. They do not become addicted when they take these drugs. They do get very vivid sensory experiences, but a lot of them have been shown to help very therapeutically, especially in areas where we don't necessarily have tools or therapies alone that will help alleviate some of the suffering that patients experience. Now, a lot of these drugs, left the lab or the research setting, and some people who were around for the Summer of Love will remember some of these drugs entering mainstream culture. And, it was a bit of a, tune out type of attitude and go about your own way, and tied in with anti-war movements and civil rights protesting. And that created a lot of tension politically. And it led, unfortunately and sadly, to placing some of these very therapeutic drugs, which had proven medicinal benefit, onto the Controlled Substances Act, particularly in the US. And when you label these drugs as a Schedule I drug, which they absolutely are not, you really control and limit the ability to do the research. And that's quite unfortunate, because probably millions of people could have benefited from the 1960s to now by using these drugs safely. And so that's unfortunate, but that is politics. I think the good news is that the tide has been turning recently. And when you look at the utility of these psychedelic drugs throughout history, whether it's anecdotally or evidence-based through the literature, we see pockets of different use when it comes to psychedelic drugs. Many people use them recreationally. Some of them are associated with a rave or music culture. Many people use these drugs spiritually or religiously to have sacraments, and others use them medicinally as botanical medicines. So the utility of psychedelics are quite profound. This is a summary. I'm not going to get into it too much, but it's a published article. And this is one of the pictures in the article that kind of walks you through from early 1900s to about 2000, and some of the research that took place and some of the political movements. So I'll just leave that there for your reference later. So it's quite a long traveled road with many ups and downs, and we're really at a renaissance currently today with respect to psychedelic research. So let's talk a little bit about psychedelic drugs. A lot of us have different opinions on what a psychedelic drug is and what is not. And there's quite a few. I'm only going to really focus on, 6 or 7 of the most popular ones. There's a lot of different ways that you can categorize these different psychedelics, but predominantly, the best nomenclature is to divide them into about 4 or 5 different categories. So serotonergic psychedelics, These are drugs that bind to the serotonin receptors and cause serotonin-like effects, typically happiness. Empathogens, or what we call entactogens, they don't necessarily bind to the serotonin receptor, but they promote your body's ability to release the serotonin, which then binds to the serotonin receptor. So similar effects, but a different mechanism. Then you have a very unique class called dissociative, and these are NMDA receptor antagonists, which is extremely complex, but its mechanism is predominantly through glutamate and a whole host of neurotransmitters, not just serotonin. And then you have cannabinoids, and so cannabinoids is cannabis. Those are CB1 receptor agonists in the brain. And so believe it or not, THC is a mild psychedelic. So all of these work a little bit differently, but some of them have similar and overlapping effects neurochemically. So LSD is lysergic acid. It's a serotonergic psychedelic, so that #1 class that I've labeled. It's a synthetic. It was designed in the lab. When used, it typically produces hallucinations whose effects can last up to 12 hours. A lot of research was done in the 50s and 60s on it. Does not appear to be addictive by any means, and 10% of the population at some point admits to trying this. DMT is N-dimethyltryptamine. This is a really remarkable molecule. You may have heard about it in ayahuasca, and which is used typically in the Amazon. It occurs naturally in humans and plants and animals. So we actually secrete this molecule. And what we do know is that some people call it what we call the spirit molecule, meaning that we secrete this near our moment of death, and it could produce perhaps profound psychedelic experiences. It is used historically in the Amazon for spiritual purposes. It has a very rapid and very potent effect. It's known as a potent psychedelic, and it also is a serotonergic one. Psilocybin is a fungi, a chemical found in we call mushrooms. There's actually over 200 different types of mushrooms that could produce these psychedelic ingredients. Psilocybin is what we call a prodrug, meaning that it's not the active ingredient until it hits your stomach, which it gets converted to psilocin. The effects can last, 6 to 10 hours, depending really on the dose and your metabolism. And these drugs, again, have been used historically for healing as well as spiritual awakening. And psilocybin is very exciting because there's at least 5 or 6, phase 2 or 3 trials currently going on for a whole host of mental health conditions. And early results with it look extremely promising. And when I say extremely promising, I mean potential cure rates of 80% for anxiety and depression. And you can compare that to current treatments we have to offer, which are around 30%. MDMA, so many people will know this as ecstasy. So this is typically seen in the rave culture. It is a pathogen, so it releases serotonin, your body's natural serotonin. And its effects are 6 to 8 hours. A lot of people call it heart opening. People feel an intense rush of euphoria and love when using MDMA. What's very exciting about MDMA is, as recent as just a couple of days ago, some of the early results of MDMA for post-traumatic stress disorder are profound. And we think, and the psychedelic community believes that within 2 to 3 years, MDMA will be an FDA-approved therapy for post-traumatic stress disorder when combined with psychotherapy. THC, tetrahydrocannabinol. This is found in the cannabis plant. It binds to receptors in our brain as well as our immune system, and its responsibility is regulation of homeostasis in the body. So THC, when used in medium to high doses, can produce psychedelic-like effects. Peyote, this is found in cactus, most commonly mescaline. It is spiritually known as the divine messenger, and indigenous communities around the world have used this for healing properties for many, many years. And last but not least is ketamine. And ketamine is the only drug here that is an NMDA receptor antagonist. It's a psychedelic, but also known as a dissociative. It's a synthetically designed chemical in the 1960s. It was really designed to prevent respiratory depression with typical anesthesia. And in the wartime, it was known as what's called a buddy drug. So all individuals in the war would carry this in a syringe. And if the guy next to them went down, they would just immediately give the injection, given how safe it was. and that would produce, anesthesia, pain relief without suppressing their ability to breathe. For those of you who remember the Thai cave rescue, when I believe it was 15 boys, give or take, were trapped in the Thai cave, a diver, a physician diver from, I believe, Australia, had to go in and rescue the boys. So all of these 15 boys, to relax them and calm them while being underwater, were given ketamine, a dissociative. That's how safe of a medicine is. We give it every single day in the emergency room to children when they have fractures to help anesthetize them. It's very safe. And what's unique about ketamine is that its effects are only about 45 minutes to an hour, depending on the method that you use it. So the bulk of my energy and focus today will be on ketamine. So what are the risks and safety of psychedelic drugs? I can't really get into every single one, but there's general themes that I'm going to kind of highlight. So this is a very, very important graph and a very, very important study published by Dr. Nutt in the UK, who used to work for the UK government on drug policy. And his conclusion when he went through all the different drugs that individuals used, his conclusions was a bit counter to society's priorities with respect to legalization. And so he looked at all of these different drugs and how the drugs harmed individuals who were consuming them, as well as how they harmed individuals around them. So others, like their family, friends, community. And excuse me, what he found is that the legal drugs were actually the most harmful. And so that top drug, alcohol, which the vast majority of us have experience with, is actually the most harmful drug from an evidence-based perspective with respect to the combination of harm to self and harm to others. So harm to self from alcohol would be like liver problems, increased risks of depression, anxiety, withdrawal, seizures, the list goes on. And harm to others would be like, motor vehicle collisions, absence from work, domestic violence. That's kind of the various social and medical issues that they're looking at when they look at this study. What's really fascinating is if you scroll down to the bottom of this list, the drugs that are illegal and typically Schedule 1 are actually far less harmful. So when you look at the psychedelic drugs, ketamine, ecstasy, LSD, mushrooms, what we see is that there is a slight risk of individual harm, and predominantly when used in an inappropriate context or setting. The harm to others when these drugs are consumed by individuals is extremely, extremely low. And when you combine those two, what you have is a substantially safer substance when compared to drugs like alcohol, tobacco, amphetamines, cocaine, etc. So I think that's really important to set the stage that in general, these psychedelic drugs are magnitude safer than drugs that we have experience with every single day. What are the potential risks and what are the potential benefits of psychedelics, kind of, again, categorizing them all together? I can't say that we fully understand all of the benefits, but the research does show a couple of common themes, and that is an increase in mental flexibility, which we call open-mindedness, antidepressive and anti-anxiety effects, the ability to facilitate mental healing or processing trauma, and something called the reprogramming of the default mode network, which I'll get into. When you look at the potential risks and side effects, generally we see in some experiences, there can be anxiety or worry when under the influence. Not all experiences with psychedelic drugs are typically pleasurable. They can be very difficult to work through some emotional barriers. You do get some systemic changes in vital signs, such as heart rate or blood pressure, but this is usually not problematic. And we don't really have the long-term risks understood. And so that's important to consider. So what is the default mode network? So the default mode network is a network of brain regions that are active when the brain is at rest. And we discovered this when someone was sitting in an MRI, functional MRI scan, and they were told to do nothing. And they found out, oh, the brain is actually very, very active when they're not doing anything. And what we found is that there's always this network that's always running. And it really is when your mind is wandering or ruminating, but it's an important concept for each of us individually, and it's important for how it, defines us individually. And what we notice is that when you give people psychedelic experiences or psychedelic drugs, this default mode network rapidly changes. And what that causes is, a huge increase in creativity, divergent thinking, versus the opposite. When you have a very rigid default mode network, it tends to be associated with higher rates of addiction, OCD, depression. And when this DMN, the default mode network, is completely shut off, which can happen with different psychedelic drugs, there's this suspension of the ego, or dissolving of the ego, which really gives many people a new perspective on what's important and what may or may not be true based on their own filters that they've designed for themselves. And so this is a really famous and important picture in the psychedelic community. The left picture this is your brain on placebo, and the right picture, this is your brain on drugs. And that drug is particularly psilocybin. So what we found is that in this, when the drug is consumed by individuals, the amount of different areas of the brain that are able to communicate that don't typically communicate to each other profoundly changes. And to have different unique insights and to be consciously aware of different perspectives really can provide immense relief for a number of different people. Bear with me. Okay, so I'm going to shift gears a little bit and talk about ketamine. So ketamine is actually the only legal psychedelic to date. And as mentioned earlier, it was designed to be a safer anesthetic. And that's because it does not block the ability to breathe. It's used very often in the emergency rooms for anesthesia. It was carried as a buddy drug in Vietnam War, as mentioned. And it works on many areas of the brain, serotonin, dopamine, but the predominant neurotransmitter is glutamate. In 2000, it was discovered to have antidepressant effects, and I've attached the study there to the right. And research has shown that ketamine can help with pain, depression, migraines. And to date, there's actually a nasal spray designed by Johnson & Johnson that can be used for treatment-resistant depression. So it is an FDA-approved drug for treatment-resistant depression. And the drug works mostly by dissociation of some of the brain's typical networks, and that default mode network is loosened up. So this is really the only psychedelic that is legal outside of a research setting that patients today have access to. How does it work? Well, it's quite easy. Okay, I'm being a little bit sarcastic. It's actually extremely complex. How ketamine works, I can't say we have a thorough understanding, but there's probably two predominant mechanisms at play. And on the left, it talks about this change in glutamate. And glutamate is one of the most important chemicals that allow the nervous system to communicate in the brain. So you get this massive increase in glutamate under the influence of ketamine. And then the other mechanism by which ketamine influences changes in the brain is by actually promoting neuroplasticity. So allowing the brain to grow new nerve cells or to communicate to new areas. So you can, under the influence of certain drugs, teach an old brain new tricks. And that's pretty hard because a lot of rigid thinking becomes very difficult to change without, intensive cognitive therapy, for example. And it's thought that these two changes, glutamate as well as changes in brain proliferation, nerve cell proliferation, the combination leads to changes in depression. And here are some studies that you can go look at if you're interested in learning more. But this shows that there is neuroplasticity that takes effect when ketamine is being utilized. Now, the medical community has decided to take perhaps two different approaches to looking at how to use ketamine for depression. And I call this the biomedical approach and the ketamine-assisted psychotherapy approach. So the biomedical approach is take the ketamine drug, administer it to people in a chair through an IV over 40 minutes, about twice a week for about 3 weeks. Let's try to minimize any side effects whatsoever, and the drug does the work. And that is traditionally what we do with every drug today. Here's the drug, take this antidepressant, you will feel better. But I fundamentally struggle with that approach. I struggle believing in an approach where passively people are expecting to dramatically change the way they think and dramatically change the way they feel by just sitting there and not experiencing anything. And that is just a belief that I have. Now, the alternative approach is different, and that's ketamine-assisted psychotherapy. And that is using ketamine in an injection or a lozenge for about 40 to 60 minutes. And we're not shying away from the dissociation. The dissociation or the psychedelic experience, the mystical experience that happens is potentially contributing to the effect. So this is how these psychedelic drugs have been used historically. And these are the two different paradigms that we're in. I'm just going to pause here for a second just to check the chat. And then I'm going to move forward just to see if there's any questions that have come up thus far. Okay, I don't see anything significant. Okay, I'm going to continue on. Okay, so those are the two different approaches when it comes to using ketamine, and I'm going to kind of go into detail with both of them. So the typical biomedical approach today, so you'll hear about what's called the ketamine infusion clinic. They administer 0.5 milligrams typically per kilo infusion over 40 minutes, 2 to 3 times a week, usually for about 3 weeks. What we do know about ketamine is that it's a rapid antidepressant. So all psychedelics are rapid antidepressants, unlike traditional antidepressants, which take about 6 weeks to kick in, your SSRIs, for example. And the results, the data shows that 30 to 40% of very, very sick, depressed patients, treatment resistant, meaning they've already failed at minimum 2 drugs, will have a response. So the most severe depressions are responding, which kind of makes us infer that less severe depressions will probably respond. What we do see is that there's an increase in these plasticity biomarkers, so brain-derived factors, for example. These are neuroplastic biomarkers. We see changes in brain patterns, as we talked about, which look opposite to what a depressed brain looks like in terms of communication. We see massive changes in suicidal ideation. So it's probably the only drug that can rapidly change someone from feeling acutely suicidal to not, which is very important. As you can imagine, giving an acutely suicidal patient a drug that takes 6 weeks to kick in is quite a difficult pill to swallow. We see that there's a reversal of cognitive deficits associated with the depression. And the effects typically last at minimum 4 to 10 days, but appear to be cumulative in nature. And what do we see from these studies with respect to risks? Small changes in blood pressure, small changes in heart rate. There are some individuals who shouldn't use ketamine through this method, such as very, very uncontrolled hypertension, severe heart failure, or past strokes. Some people experience headache. Nausea and vomiting is probably one of the more common symptoms. And you can feel drowsy. Some people feel anxious or some dizziness. We do see in recreational users, so there is a small segment of the population that uses ketamine recreationally, and they get this chronic cystitis, so inflammation of the bladder. Mind you, we haven't seen that typically in these studies, but that's still needs to be researched, but appears to be only in recreational ketamine users. And then there is a small percentage of people that do abuse the drug. Now, there's 2 probably very important studies, which I'll just kind of highlight the results that kind of led the way with these IV ketamine clinics or approach. So the first one was a randomized trial of ketamine in treatment-resistant depression. And what they found is that the ketamine works substantially better than placebo. 71% of patients had a response to the ketamine, and 29% met remission, so no longer having depression 1 day after the infusion, which is pretty remarkable. And people would experience some of these benefits within 2 hours. And then there's a double-blind randomized placebo-controlled study, which is kind of your gold standard in medicine. And what they found was that using ketamine 2 to 3 times a week at a certain dose, 0.5 mils per kilo, actually maintain the antidepressant effect. So the first study really showed that it helped with depression, and the second study really showed that we could sustain some of the effects by dosing it in a certain protocol. And that protocol really came from electroconvulsive therapy, which is, twice a week, typically for 3 or 4 weeks. And that was just completely arbitrary. They saw clinically significant changes in depression scores. Patients tolerated the drug with very minimal side effects, and the more increased frequency of use led to decreases in dissociation. Now I'm going to shift gears a little bit and talk about ketamine-assisted psychotherapy. And so this is a very different approach. This is where you use the molecule ketamine in this instance, but you want to use that as a tool to do the hard work, which is the therapy. So it's admitting that the drug does help with depression, but it's more so informing patients that the drug will give them a window of opportunity to make systemic changes in their life. And with therapy, hopefully we can instill changes that they can carry with them. But the individual is responsible for their own healing and their own ability to get out of depression. It's not the drug's responsibility. And that is a very philosophical, different approach to how we do Western medicine, where a lot of people expect or have the expectation that if I take the drug makes me better. This approach with assisted psychotherapy is we're going to give you the drug, we're going to have your brain is more neuroplastic, we're going to try to influence positive change in your life, and we want you to carry that every day so that you can be your own healer. There's a famous physician, Stan Grof, and what he talks about is called the inner healing intelligence, and that is just like when you have a cut on your skin and your skin has the ability to bring platelets and white blood cells to it and slowly heal the tissue, your body has the same power to heal its mind. It's just very hard to access. How this works is you get a preparatory psychotherapy session, and that's really to explore your readiness to have dramatic change in your life. And then following the IV experience, you get a number of drug sessions targeting peak experiences. And then after 2 to 3 of these drug sessions, you get another intense psychotherapy session to try to integrate what you've learned. So it's very different than the IV approach, where the IV approach is extremely passive. You get the drug, you're on your own, and hopefully the drug makes you better. This is, you get the drug, we realize you're going to have a psychedelic experience potentially. You're going to have neuroplasticity, and we're going to work with you to understand what the drug is trying to influence with respect to changes in your life that will lead to living a better life with less depression, less anxiety, or ability to process trauma. What's really important is the set or the setting. And so using, ketamine at a rave or mushrooms, at a party is not going to produce the same results as intentionally using these drugs in a very therapeutic setting with a therapist when you are ready to make that change. So what we typically do is offer patients eye shades, very relaxing music, and we encourage them to look inward and to try to work out whatever it is they need to do. So that setting, the place that they're physically located and what it looks like and feels like, and the mindset, whether they're ready or not to make dramatic changes, is fundamentally valuable and important to having positive effects. Okay. And there's a whole host of studies that date back to the 1970s. So if you look all the way back, we've actually known that ketamine, when used with therapy, really can help patients. And so in Mexico in 1971, 150 neurotic patients had, 85% had positive outcomes. In 1973, 100 patients in Iran with a wide variety of mental health diagnoses took ketamine. And what they found is that with psychotherapy, 91% felt they were doing substantially better. And then over a period of almost 20 years in Russia, they did randomized trials of ketamine intramuscularly at quite big doses, bigger than we use in our clinic. And they found that for alcohol and heroin dependence, two of the most deadly, most addictive drugs, they were able to, encourage people to abstain from these drugs as high as 50% by using 3 sessions. And if anybody knows anybody addicted to drugs, that's a remarkable outcome. It's extremely hard once addicted to change that. Some more research evidence looking at this ketamine-assisted psychotherapy published, just a number of years ago, was quite profound. So this was a study done in a number of different clinics, mostly in California and Texas. And it was 235 patients at 3 different sites. There was not a placebo control. It was an open label study. So they looked at everybody who took the ketamine. And what they found was that there was significant decreases in symptoms, especially in a segment of the population, so severely sick and elderly. They also found that the more severe the depression was or the anxiety, the greater the response. What was interesting about this study is that it wasn't limited to just depression. Depression was the number 1 symptom, but anxiety was number 2, as well as post-traumatic stress disorder, number 2 and 3. They did find that, only 1 to 5% couldn't tolerate the drug. So 95% of people could take the drug without significant side effects. And then interestingly, if you practice medicine, that for whatever reasons, there's always a small percentage of patients the drugs just don't work on. So 1 to 2%, despite taking the drug, never had the experience. So they're obviously not metabolizing the drug the same way that the rest of people are. So they probably have a genetic mutation of some sort. And so when you kind of graph the depression and anxiety scores, you can see that there's dramatic changes after using ketamine. And so what they did in these studies was use ketamine intramuscularly, and they applied the psychotherapy as well with it. And they found that that worked quite well for depression, anxiety, and trauma. Okay, I'm going to pause there again and just kind of take a peek, just to see if there's any questions. Okay. So there's a couple questions I'm just going to address, just to pause there because I'm going to shift gears. So someone talked about, is the dosage of ketamine used to treat depression the same as ketamine infusions? Yes and no. The IV ketamine is a little bit more protocolized at a certain milligram per kilo, and there is some room for fluctuations. With IM ketamine, the first session is typically more exploratory, so starting with a low dose to see how the patient responds. So it's a very personalized experience, and depending on how the patient responds, the dose can be escalated. So question is, doses have been shown to treat depression are sub-anesthetics. There tends to be considerable variation to how individuals respond to ketamine doses, but with overall tolerability allowing for opportunity to determine therapeutic dose. So yeah, absolutely. So just a comment there that is with all things in medicine, there's a lot of art to medicine. It's not just concrete science. Each of us is very unique. Not everybody will respond, therapeutically to any drug, whether it's an antidepressant or it's a psychedelic. So we're all very unique. Someone wants to know what my thoughts are about companies removing hallucinogenic components. I'm going to actually talk a little bit about that soon, so I won't answer that one. Okay, and there's some other comments as well. Okay, I'm going to just kind of continue on, and we're going to open it up, and it'll be a little bit more dynamic near the end. I just kind of wanted to pause there, given I'm going to shift gears a little bit again. So let me share my screen again. Okay. So talking a little bit more about psychedelic-assisted psychotherapy. So everybody wants to know, well, when you take a psychedelic, what is a trip, or what is an experience like? Well, no 2 trips are the same, probably because we're made up of 1 billion neurons or more, probably 1 trillion, and I'm sure none of us are wired the same way. But what we do know is that, you could take the same drug, but in different environments or different mindsets and get completely radically different experiences in the same individual. And that's that set and setting, which we talked about. Now, there are these themes, though, people with a lot of experience or people who've published the use of psychedelics, they've kind of categorized some of the different themes that individuals have. So the sensation of being reborn tends to be a common theme, which kind of fits with people coming out of these psychedelic experiences with a new, fresh look on life. A lot of people have the experience of dying, or what we call a near-death experience. And near-death experience is what we call NDEs. Many people who've had them will report psychedelic-like experiences when they're close to death. And if you talk to them, they dramatically change their lives after having these near-death experiences. Unfortunately, sometimes it takes that, on your deathbed until you kind of wake up to make some important changes. So these drugs also can facilitate that experience. Dissolution of the ego. So a lot of people lose sense of who they really are. Some of the filters that, your childhood or your experiences has kind of instilled in your mind, and how you filter all the content through certain areas of your brain, that tends to kind of dissolve a little bit. And then when you kind of come to and the drug wears off, you can kind of reform those filters, perhaps more open-minded filters. Many people have mystical or very spiritual experiences that are hard to describe, which can be extremely unique. And, historically, these drugs are used in a number of different cultures to heal or to promote connection with the heavens or space and time or whatever it may be. And a lot of people will come out of these experiences and they'll say something that might sound common sense, like, wow, I really need to spend more time with my family. That seems common sense, that seems intuitive, and we probably say that to ourselves all the time, for example. But they really believe it. It's like they visited a place that feels more real, and the data they collected in that experience is actually going to allow them to make the change. And so the light is going on, but they're actually moving towards the light. And the sensation of oneness, that's probably one of the most common themes we see, is that individuals who use psychedelics will get a sense of that there is no you and I and earth and I and space and time. It's all kind of the same type of stardust. And so this connectedness between nature and an individual seems to be heightened when people use psychedelics. And that can be, a very liberating feeling. What we do know is that ketamine specifically has very unique dose ranges. So low doses of ketamine can produce what we call a more trance-like state. So using like a lozenge of ketamine can allow some people to be extremely open to having conversations, but, a very, very intense social lubricant that really allows us to remove some of the barriers or filters that we have to kind of get at some of the deeper issues that we may be dealing with. And then the higher doses of ketamine, typically given through IM, they can produce that rapid dissociation, what we call a mystical experience. And that's what's going to lead to a transformational experience. That's where the possibility of going in with one version of yourself and walking out with a completely different version of yourself happens, is at those big doses. And what we do know is that magical solution thinking can be a very powerful tool to activating behavior when done correctly. So somebody asked, intuitively, do you have to have psychoactive effects to get the benefits? And, someone's commented that there's a number of companies that are, releasing press releases saying that, hey, guess what? We can take out LSD's psychoactive properties, and you can take LSD but not feel, sensory changes or any hallucinogenic effects. And so, what does the literature show? So I'm not going to tell you my personal opinion, but you'll probably be able to garner it based on the literature I show you. So pharmaceutical companies know that when you can remove some of the side effects from some drugs, that you'll have a much bigger market, and you'll probably get doctors to buy in a lot more. But the studies show pretty clearly that if you take away these dissociative effects, you lose the medicine. And so there's probably companies who've tried to design 6 or 7 molecules that look like ketamine that don't have the same dissociative effects. But when they run them through their trials, they just don't produce the antidepressant effects that ketamine itself does. And so by and large, the literature suggests that the experience is necessary to have the outcome. Obviously, ketamine itself through IV has literature to support the drug working. But I think, and I believe that if you're going to have dramatic, profound changes in the way that you look at yourself or the world, you're going to have a dramatic, you require a dramatic or a profound experience. Having a passive experience and not feeling anything and then just having a dramatic change in life just doesn't seem to coincide with each other. We obviously need a lot more literature, but by and large, not just ketamine. If you look at some of the Johns Hopkins studies with psilocybin in end-of-life cancer patients, they're showing many years later, one dose of a psychedelic experience with psilocybin combined with therapy can produce almost 4 or 5 years of changes in anxiety and depression. So, you know, I can speculate, and my speculation would be that, you know, if you use a drug that doesn't give you dramatic changes, you're going to need to keep using the drug. And if you use a drug that produces these profound changes, you're not going to need to use it as much. And that's what I believe, but I think we need more literature and evidence to show where it falls. But by and large, I think if you're looking for a transformation, you're going to need dissociative psychedelic experiences. And thus far, the literature supports that. Okay. So what is the research landscape currently with respect to psychedelics? So I'm extremely excited. And like I said, you know, 4 or 5 years ago, my opinion on psychedelics were completely misinformed and uneducated. And it wasn't really until patients started telling me that they were using, you know, magic mushrooms for cluster headaches, and I had to do research and look into it, that I was, you know, my brain opened up itself. I'm very excited because the approach to these psychedelic drugs is extremely research and science-based. And I strongly believe in the medicalization of these drugs. I think they should be accessible for everybody. And I think we need to do the research, and I think we need to develop the right protocols to use them in the right setting. And if you look at the research, it's profound. So psilocybin is being studied for end-of-life anxiety, nicotine addiction, treatment-resistant depression, anorexia and other eating disorders, MDMA-assisted psychotherapy for post-traumatic stress. MAPS is doing some great work there, and they released something recently showing that, you know, when they publish it, there's a 90% chance they have something profound. MDMA psychotherapy for anxiety and autism. So autism is a condition that we really struggle to treat. We don't have drugs for, so it would be remarkable if these drugs could show promise for not just autism, but a whole host of diseases where we don't have any therapies. Cocaine addiction, alcoholism. We don't really do a good job treating a lot of addictions. We do really struggle, and it can be extremely expensive. So if these drugs and these studies are positive, we really are on the cusp of a paradigm shift in how we approach mental health. So what do I believe in? Well, based on the early results, which will eventually move to these phase 3 and eventually, you know, bring a lot of these drugs to market, what it looks like is that the future is a little bit like this. You'll enter a facility that specializes in psychedelic experiences or psychedelic medications, will understand the specific condition you have, and will match up the molecule, so it could be ecstasy, psilocybin, DMT, LSD, ketamine, to therapy, a specific therapy protocol that's been researched and evidence-based. And what we're hoping to do in, let's say, you know, as little as 1 to usually 4 or 6 sessions, is to try to cure you of what ails you. Now, whether those effects last 3 months, 6 months, 12 months, or 5 years, we don't have all that data. But the approach is going to be radically different than taking a pill every single day for the rest of your life, hoping it helps a little bit. So this is what I think the future is. This is what the science is starting to lean towards. But of course, we still have a lot of barriers to overcome and a lot of research to do. So what is Field Trip Health? What is the company that's putting on this talk today? What do we do? Well, we're trying to solve a problem. What we realize is that depression, anxiety, mental health in general, 1 is an epidemic, and 2 is the therapies work for some, but they don't work for everybody. If you look at the data, you know, 55% of patients relapse after their second antidepressant medication. And we know that if you take a second antidepressant that doesn't work, the chances of a third or a fourth or a fifth one, the chances of those working go down to 10, 5, 0% eventually. If we look at the relapse rate, within 4 months, that's the average time that a relapse can happen for a patient after a second antidepressant. And one of the biggest challenges, which I alluded to, is that people who are really suffering with acute suicidal ideation, our current therapies sadly take 6 weeks to kick in. And I can tell you as a student health physician, anxiety, depression, and I treat a lot of international students from war-torn countries with post-traumatic stress. I really struggle with the tools I have today. It's really difficult to tell a patient, I'm sorry, you're suicidal. I'm going to give you this medicine. It's going to take 6 weeks to kick in, and I hope it works. And I know that, the chances are maybe 30% that it might work. And I got to wait 6 weeks and, in some cases lose substantial sleep myself, worrying about that individual. And I can only imagine what they're doing while they wait passively for this to work. So what happens when you switch medications? So as I alluded to, as one medication fails and the second medication fails, the probability of a third or a fourth medication working just decreases and decreases. And sadly, you would think in many instances people go on antidepressants and they do better. But I can tell you as a clinician who's prescribed no fewer than 1,000 antidepressants in my 5-year career, I'm always trying a second or a third medication in a huge percentage of my patients. It's very rare I try one medication and effectively get it to work right away. So we recognize that this is, one, a growing epidemic and a problem. And two, we recognize that there is another alternative for unique patient populations. And we want to be a leader in providing a safe space to use these therapies safely, with the right environment, with the right setting, with the right therapy. And we want to provide that space, and we want to help influence the improvement of mental well-being for individuals around the world. These are some pictures from our Toronto clinic, our flagship clinic downtown. We have 4 ketamine rooms where we do injections, consultation rooms, spaces for meditation and mindfulness. And we plan to launch in a number of other cities, which we are currently underway. This is what a treatment room looks like at Field Trip Health. You can see this does not look like your standard medical office, which is typically sterile. We have zero gravity chairs where patients are invited. They are encouraged to relax. The space is all designed to reflect inward. We provide you with noise canceling headphones. We have custom curated music that is designed to peak and flow with the experience of the ketamine. We have weighted blankets, and we always have a sitter or a therapist available with you at all times to monitor you. Our program is for 5 steps, and that begins with a psychiatric evaluation. So just to double check that the patient meets the criteria. We then go through a psychotherapy preparation session. We then invite you to treatment sessions, which will be therapy with the drug. And then we have individual therapy sessions after every 2 doses of ketamine IM, where we will try to understand what your experiences mean and how we can activate some of the learnings from your experience. This is our clinical team. And I'm very fortunate to have Dr. Joseph DeLeo with me here, who can also answer any questions, hopefully. And that really concludes my presentation. And I want to just leave you with another couple of references there, some TED Talks that are a little bit easy to digest. And if you haven't read Michael Pollan, How to Change Your Mind, that was also a very influential book for me to kind of confirm that this was the direction that I needed to head into individually. And I've also left the references throughout. So that really concludes my presentation. There's my personal contact information. And at this point in time, I'm going to shut down the presentation and open it up to questions. Thank you. Okay, so we have a lot of questions coming through. And so I'm just going to kind of go one by one, and we have Dr. DeLeo as well here. So feel free to chime in, Dr. DeLeo. So I'm just going to scroll down and go to the questions earlier first.
Just a note, Mike, just a note. I've been doing my best to address some of the questions as they're coming up, but it might be worth kind of rehashing a few of them, because some of them are really good ones. It might generate other questions as well. So if you see JD, that's my comment.
Okay. So some people are asking about other conditions such as OCD, weight loss, and in eating disorders, and Dr. DeLeo left some commentary there. I think there's a lot of, again, interesting work being done. I think it's a little bit early for some of these conditions, but I also think that this is a field that's very unique in that no two individuals are the same. And I know medicine likes to place labels on people, like you have this depression and you have this anxiety. I think individuals are far more complex. And so I think regardless of, the label that an individual has on them with respect to their mental health, I think if people feel that they've tried adequate therapies and they haven't helped, it might be reasonable to have a consultation with our psychiatrist, which is, obviously no cost, just to see if it's an appropriate therapy. The evidence definitely is best for treatment-resistant depression with respect to ketamine, but we use drugs off-label all the time for other conditions, and it's really just understanding the risks and benefits in that individual situation. So I find myself seeing many patients who feel quite desperate, and so if patients, do feel that way, they might be a decent candidate for ketamine and to consider at least the risks and benefits. So yeah, questions about the gaps. So there's a lot of gaps in the literature. Some gaps are, how long do you have to treat patients? What is the best protocol? Is it twice a week? Is it twice a month? We don't really know if these effects are going to last 6 months or 12 months or 5 years. So we still need to learn how often people need to do it. Do they need to come in once a year for a booster? So those are probably some of the major gaps. I think we understand the harms pretty well thus far, but the longevity of the effects is probably one of the biggest gaps. And really, which drug is best? So there's 6 or 7 psychedelics. Is one drug substantially better than a different one? We don't have any head-to-head comparisons of any of these drugs. So this is a great question. Is it harmful for people under 25 years to old to use like cannabis? So yeah, as a bit of a cannabis expert, the cannabinoid system is developing in the brain until what we say the age of 25. And there's this notion in medicine that once your brain hits 25, there's no more neuroplasticity. But as I told you, drugs can actually enhance neuroplasticity. So I think, the younger you are and the more that the brain is developing, you just want to be cautious of it. Is it an absolute contraindication? No, but I think it's like a relative contraindication. It would, require a bit more attention, a bit more understanding what the individual has been through. But I don't think it's absolutely contraindicated, and it doesn't have that same body of literature that cannabis has that is associated with, worsening anxiety and depression later in life for very young people who smoke cannabis. And the format matters too, right? So with cannabis, it's really smoking. It's not like the CBD oils that are contributing to potential negative outcomes on brain development. So great question about why ketamine over psilocybin. It's just a data thing. So the best data to date is probably for treatment-resistant depression is ketamine, but psilocybin is being studied. So again, we'll have to see. That's a gap. Is psilocybin better, equal, or not? We don't know. Someone's asking, what is the criteria for treatment? So I do believe if you head to our website, fieldtriphealth.com, there is some forms that you can fill out, and there's like a mini screening protocol on there. But by and large, we're just looking at, is it indicated? So do you have treatment-resistant depression or treatment-resistant mental health, which really is the failure of 2 medications, adequate trials of medications. And then we make sure you don't have any contraindications. So if you've had a recent head injury or a history of schizophrenia, and a couple of other issues, then it wouldn't be recommended because there's a higher increased risk. But by and large, most of our patients still get a psychiatric assessment, and we kind of walk you through whether we think it's an appropriate or inappropriate therapy, what your risks are, what your benefits are, and try to help you make an informed decision with us. someone asked about the psychotherapy, so maybe I'll just be quiet for 5 minutes and let Dr. DeLeo share a little bit more about the psychotherapy protocol that he's helped Field Trip develop and his approach.
Yeah, I appreciate the question. It's a very good question. And I think in some sense, it really gets to the value that we're hoping to add in these conversations. As Dr. Verbora mentioned, that we're broadening the model beyond just a biomedical model. And we're thinking about this more as a biopsychosocial intervention. I might even go as far as to extend it to say biopsychosocial spiritual intervention. So in that sense, we're incorporating a client-centered approach that leverages a brief psychosocial intervention that we know works for depression. The literature in clinical psychology has certainly been focused on addressing depression, mood disorders, or affective disorders more generally. We recognize that very rarely do individuals present in the ways that they might say in research trials. There's a high degree of complexity in folks' presentations. They're often coming in with comorbidities, mood disorders and substance use disorders as a means to try to cope with complicated mood states. So there's a line of literature that's been around since the 1970s suggesting that brief psychosocial interventions that have a behavioral orientation are helpful in re-engaging people in important life areas that they might otherwise become disconnected from when their moods are not serving them or when their motivation is not carrying them forward. So kind of thinking about it more broadly beyond kind of the biomedical, we recognize that ketamine, in the same way that maybe other psychedelics, it can serve as a catalyst to supporting the active treatment components of what we know work in psychotherapy. So this is it's a promising new area to kind of think about how we can quintessentially manifest that biopsychosocial intervention, which at least in my training is more described as an art than a matter of practice. And I think here at Field Trip, we're certainly hot on the trail of figuring out how to blend these approaches in a way that's integrative, that's focused on the client's well-being, and leverages the immense, powerful effects of these potent medications alongside a therapeutic orientation that acknowledges the challenges of making changes around any mental health strategy.
Great, thank you. There's a couple people asking about the costs of it. So typically it's not going to be covered by a private insurance company typically, unless there's, some extenuating circumstances like an insurance claim, disability claim of some sort. We've really worked hard to try to price, every hour at the rate of what you would pay for, psychotherapy. Each individual might require a different number of sessions, but our goal is to try to make this as accessible as possible. And so if you are interested or you think that this is an appropriate therapy for you or a loved one, just head to our website for all the information and content. We have referral forms that you can send to your family doctor, your psychiatrist, and you can get in touch with us and we can, speak specifically to what your needs may be. And so someone wants to know, some individuals may live in Northern Ontario or difficult to get to Toronto. And yeah, we recognize that. And we have a number of patients and clients who, are driving, 6 to 8 hours to come to us. It would probably require, 2 or 3 visits to the clinic for at least 2 to 3 days at a time. But again, we're very patient-centered. So, we will work with our patients to try to find, the most cost-effective or the best program that will work for them. We want to be cognizant of what it's going to take, and we don't want to, give you less than what's required. So we do find ways to try to balance people who are coming from out of town to try to condense it if appropriate. But we understand that's a barrier, and we hope that, as the science and literature starts to ramp up, we're able to open clinics, not just in Toronto. We recognize that this is an epidemic, and, we hope and intend to have substantially more clinics that will be much more accessible. Do you have anything to add, Dr. DeLeo, to any of these questions or anything else you want to finish up with?
Yeah, I'm doing my best to kind of pepper in as you've been presenting Dr. Verbora, and hopefully was able to address most of the questions that are coming in. I recognize that there's a lot more that can be said about the psychotherapeutic approach, and I take some pride, at least, in being able to articulate that. One of the challenges that I've encountered, at least in learning about psychedelic psychotherapy, which places a lot of emphasis on setting and supports, tends to reinforce the notion that clinical presence is important for clients to establish trust and a strong therapeutic alliance that serves as the basis of this work. What's often lacking, at least in my experience, is an articulation of what the integration work looks like. So I think at Field Trip, we've really tasked ourselves with being able to articulate that in such a way that it's understandable, not only for, say, providers, practitioners, and so on, but for the client. And it's certainly important that the client understands the rationale of the treatment. And one way we've been able to do that is by making it a values-based conversation. So we're really trying to understand our clients' motivations, their intentions for seeking out treatment, some of the challenges that they may have encountered along the course of trying to manage a very complicated condition, and keeping that as the basis by which we can individualize any plan moving forward in a manner consistent with evidence-based principles in behavioral therapy. So it's an interesting set of conversations. No two are the same because no two individuals are the same, even though they are often presenting with, say, common conditions like anxiety, depression, and no doubt elements of trauma. So I do think that a client-centered approach that is able to leverage a values-based conversation will really inspire the level of engagement that's needed for individuals to forge ahead with some confidence that this treatment is the right treatment for them.
Thank you, Joseph. Dr. D'Elia. So yeah, the webinar will be available for everybody who's registered. I believe once this ends, you'll get a link back so you can go through some sections or look at some of those references if you're very interested. Our website is available, fieldtriphealth.com. We're on all the social media platforms. Reach out to us in any which way. I also provided my personal email at the end. If you have very specific clinical questions, I'd be happy to engage. We'll be doing this again, hopefully in maybe 2 to 3 weeks. We'll be able to do another one and maybe share a little bit more about the very rigorous therapy protocol that he's developed. And I just want to thank everybody for coming and attending. And I look forward to sharing more about this emerging field and really helping to set the stage for a paradigm shift in what I believe is really necessary to help people. So thank you very much.
Thank you, everyone.
Take care, everybody, and have a great night.
Bye now.